Now we're going to start the second part. And this second part is going to include 5. I'm very excited to listen to all of them. I'm not saying I wasn't excited in the first part, but they are all share 2 things. Number one, they're all young in terms of perspective, not in age. So don't take me wrong, old and young. But they have a different perspective. And as I said earlier, those who have just joined us, the World Bank, United Nations are looking at young because they think they are critical and the cornerstone for any sustainable development strategies in any countries, because those are the group of, if you like, citizens of any country who were born or are born within this digital revolution era, if you like. They have born with their mobile phones. I didn't see the mobile phone until I left Sudan. So this generation, they have born with the mobile phone. So that means they are well connected. At my age, if you have told me how this is what we're trying, we're using simple technology to show to people they can use it. So what we are doing here is very simple. Other people can do it. They can do it better, actually. So we're going to listen to the 5 perspectives from different, some of them are already experienced in their field, but what impressed me about them, I know they're all diaspora because they are here and in Sudan, but I was very impressed Muhammad, for example, you finished a degree already and then you're doing a second one now, right? And also Rayan, right? You finished one and you're doing another one. I was very impressed. All of them had studied in very high, very prestigious universities, Cambridge, Newcastle, and so on and so on. And they work in a very, very prestigious places, which take me back to the point before that was raised earlier. Despite the system in Sudan, I don't want to call it broken, but despite the challenges we're facing in the medical field in Sudan, in the education system and so on, we still have excelling stories like those guys because they studied. Abdulrahman, you studied in Sudan, right? And Ahmed studied in Sudan. And you all studied here, right? The 3 of you. Now, despite that, they are here, they are working, they are leading in very critical topics like we're going to listen now about. I like the title, which is really exciting. Emergency care in Sudan, what is the perfect model? We heard about this question before, and emergency care is critical for any health system. So Ahmed is going to talk to us. And if you can, please, introduce yourself, Ahmed, when you start, rather than I click and talk about you. Can you introduce yourself? And I will, again, raise my hand when you have like 7, 8 minutes, and then I will give you another shout when there's 1 minute. Okay? So the floor is yours.
Thank you. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. My name is Ahmed Eltahir. I'm a registrar in emergency medicine in Manchester, and I've been there for 4 years now. As you can see from the title, my talk is about emergency care in Sudan, with a question mark. If you have a model, actually, and what would be the right model, if any. I graduated from University of Khartoum, and I'm afraid I'm in a lost generation. So I'm no longer young as Abdulrahman and the guys who are going to speak after me. But I'm not an expert in my field yet, I would say. Hopefully I'll be at some point. I only have 10 minutes to talk, so that would be more of a taster than for the topic. And it's very hard to talk after Dr. Muna and Dr. Mayada. And I think after these inspirational talks they had earlier, it's going to build on that. But it's going to be more of a story. Actually, I have 2 stories to tell. So I was lucky enough to join the Northwest Air Ambulance for 2 years when I went to Manchester. It's a very exciting job. It's a good story because it's a charity. At the same time, it's a collaboration. So the Northwest Air Ambulance is basically a charity. We get the pilots from a company, private company. We get the paramedics from the Northwest Ambulance Service. We get the doctors from within Shaw Hospital, which I was one any registrars from there, so I was one of them. And they all work together to run the service. We attend all kind of this all like shot by my mobile camera, so nothing from the internet or nothing photoshopped. You work in quite adverse weather sometimes, and none of the patients died, luckily, from this picture. So we had 2 guys on the aircraft who went away walking, which was quite impressive. And we had a guy in this car which managed to get to the hospital with some bad injuries. But again, he was alive when he got to hospital. I think he's still alive. But this is a good model of the collaboration between different sectors. So private sector, government, charities, all working together in a very good model. I know Scotland has 100% governmental air ambulances. Some other places, it's a charity employing the paramedics. But the Northwest, I think, model is one of the interesting ones. So this is the first story. The second story will be one of the patient's journey. So it was winter, so possibly autumn. We've been called to a guy who fell off a valley. He was walking with his company's colleagues on a day out, and he fell quite a height and landed there. So initially the call went to 999, and what normally happens is they send what's called an RRV, Rapid Response Vehicle. There will be one paramedic, single paramedic to assess the situation. They also send what's called Mountain and Rescue Team, which are, again, a charity, volunteers from different backgrounds. But they are more equipped and skilled in going into these environments. So these two went there, and they send an ambulance. When they arrive, they assess the patient, they assess the situation, and then they call for an air ambulance. So we are fourth in line. We got there, the patient was lying on the floor, multiple injuries, and there was no way of us bringing him back to the aircraft. So we had to call the SECA, which is the Royal Air Force, the RAF. And you can see the background there. And that's inside the SECA. So one of the doctors had to go with the SECA to bring the patient to hospital. As you can see from such a story, someone we didn't know his name, his nationality, his background, had mountain rescue, 5-6 people, had an RV, had an ambulance, had an air ambulance, had the military sending an aircraft for them. And he had to be winched up to the aircraft to be taken to the hospital. This is as good as it gets for any, I think, emergency care system in the world. And it was with good results. The patient needed to be treated while he was still in the valley. He needed to be treated after he was taken to a major trauma center in Wythenshawe. And he got lucky there. But the whole point is, all these systems were coordinated by one center, which was the 999. And the dispatcher decided whom to call and when to call them. And when they're being called, they answered. There was no complexity in why we're getting the military to a non-military person, and why we're getting the charity and the volunteers, or why we're getting their ambulance. So all these are working together. So how we can move from this example to Sudan and the situation there. So this is quite new. So the WHO didn't have much interest in emergency care as general. It's very hard to have success stories there. They have better stories with the smallpox eradication and other stuff. So infectious disease was quite a hot topic. Non-communicable disease started to come quite recently. And over the last 10 years, they started to work on what's called emergency care system framework. And basically it tells us that from you becoming unwell, having an accident, which is over there, till you get to a hospital, there's a whole system in between. So back to Sudan. What Dr. Moon and Dr. Mada talked about earlier was preventing the initial injury, illness from happening. That's the role for preventive medicine as a whole. And then there's primary health care, which should provide service for people with non-urgent stuff. But then what if it is actually an urgent problem or quite a bad injury? Then you need, first of all, bystanders who knows what to do. So calling 999, whatever, which we don't have in Sudan, and actually know when to touch or not touch the patient. I think we all have possibly stories from our families when someone fell from a height and ended up with people carrying him and breaking what left from his back or cutting his neck or whatever. So we would have bad experiences from people intervening without knowing what they're doing to patients there, and not knowing whom to know and how to do it. But then I think our biggest problem is getting the patient from the scene where the injury happens to an emergency department or wherever is relevant. Because what's happening here, for example, in the UK, that we decided to take the patient to a normal A&E, to a major trauma center, if you need what's called a PCI, if you have a heart attack, if you had a stroke, he needs a hyperacute stroke unit. So all this is decided by the ambulance triage system, which we lack in Sudan. So people don't know where to go. They'll go to the medical A&E and being told to go to the surgical A&E because they have to do their own triage there. And again, the baseline for an ambulance service would be 2 people. One of them should be trained. So you need a driver and someone trained. And I think in Sudan, more or less, it's more of a van with a driver, a siren, and maybe some lights on top. And maybe an oxygen or not, it depends. But that would be the optimum ambulance service. And again, the ambulance service here is the same service for transport, for emergency care, for non-urgent care, for transfers between hospitals, while in Sudan it's more scattered. So having said that, they still have charities involved in terms of St. John's. They have private ambulances, but they're all coordinated with one service. So you have the dispatcher who decides if they need to go for private ambulance, they need the high skills for paramedics. If they need to go for an air ambulance, as happened to us, they seek for mountain rescue. So if the patient passes that, if they get to the ambulance, then they need to go to a relevant A&E. And there, as you can see here, they need a provider, again, a medical trained person, which can be a nurse for triage, a doctor. And with that, with the emergency unit, which can be of different skills, you need at least an intensive care unit and a theatre for operations. And that's all. I mean, this is the minimum unit you need to have for an emergency care system. I'm not saying this is the ideal one, but this is the minimum you need to. And I think in every part of the country, they need to have one of these units. So this model is new. Luckily, the WHO does have an assessment tool, so you can assess your country and see where exactly you are in the system. And then you can see how long you have to go to get to the system. So back to Sudan, we do have a very scattered and disintegrated system. So we do have a separate military hospitals, we have a police system, we have the governmental, and we have the private hospitals. And we do have charities, but in a poorly coordinated way. And the trouble is, emergency care is not attractive for private sectors, so you won't see them doing emergency departments as private because people who come there are in emergency and they won't plan for money. Some countries like the US went around it. They have a law and a legislation, and every private hospital, which is the majority in the US, have to treat people in emergency care. And then there's a different way of, for example, Ahmed is going to talk about the economics of that and how to fund it. But this is the point. So coordination and integration and collaboration between these different sectors is crucial. So we do have resources. I think the military has big buildings and big hospitals. Same for the police in Sudan, while the governmental are of a low quality, lesser impressive facilities, I would say. Not much of a charity, economic emergency service at all. And the private is there, but again, if you don't have the money, you won't be able to get there. There's no clear legislation to force them actually to treat people in emergency care. And if you allow it to happen, everyone will go to royal care, for example. Because there's no ambulance to take to decide who is actually sick enough to go to a hospital to be treated there. So the whole system needs to be looked at and decided how to be done. So legislation, again, will be important to move us from where we are now to get the private sector involved. I think the third point will be the expertise. So emergency medicine as a specialty is pretty new. I mean, in the US, it's there from the 70s. Here in the UK, it's still getting there. The first consultant was back in, I think, 74, but we're still making our way as a specialty in the US. In Sudan, they graduated the first batch of emergency consultants or specialists. However, we still have a long way to go because you need a pool of expertise to help Sudan basically and develop the specialty and develop the whole system. Having said that, I'm not aware of any paramedic as a specialty or as a career in Sudan, and that's a big gap that need lots and lots of people to get in. They can come from different backgrounds. They can come from a nursing background. They can come from a medical background. But we need to work on that. And I think we need to focus on developing this career. And I think the last point, which is quite important, will be the charities. So we do have charities. People here are willing to help in Sudan. But as you could see from the first story, basically, they have a whole air ambulance service run by 4.5 million a year 3 aircrafts, 2 in Manchester, 1 in Blackpool, all by public fund, by charity money, that's all. And they're still managing to do that. I think the system can be brought in Sudan. It won't be exactly the same system, because we don't need air ambulances as of now. We can have it in the future, that'll be a plus. But I think we need more of a basic service to be provided to people before we can move on to say we have air ambulances. I think last but not least would be integration and collaboration. I think the government should have a strong will into collaborating and integrating the military, the police, the governmental and the private medical facilities together to get a better emergency care. What's important, people have to differentiate. I mean, people can talk about having different models for emergency care, and it's always scattered. Maternity service, stroke, asthma, but we have to be pragmatic. The example I got from the lady who presented this from WHO is asthma is a totally preventable disease. By good education, by good management, by a good system, you can prevent death from asthma. While a stroke will happen, and if it happens, there's not much you can do as an emergency service. You can get them to a stroke unit, you can try to thrombolize, some will die afterwards, regardless of what you do. And then the aftercare, the new rehab, is a long journey, quite expensive journey. As a poor country, you have to decide where you're going to spend your money. You have a limited fund, you have limited resources, and I think it's sad, but you have to decide which services need you more, and you start to build on that. And I think that's my 10 minutes talk. Thank you.
Thank you.